So hopefully we've got some people zoomed in or whatever platform we're using now, brand X, brand Y. But I'm thrilled to introduce our speaker today. Everybody who's been involved with the teaching program at University of Tennessee in Chattanooga knows Dr. Poole. He's been a stalwart for, how long you been here now? 18 years. So he's seen me come and seen me go. And but he graduate of the University of South Alabama Medical School, and then moved upstate to Birmingham, where he did his internal medicine residency and his renal fellowship. Been here for 18 years. He's our chief of nephrology. He's stalwart in the teaching program, and really gives usually, I'm gonna put some pressure on you, usually gives a really good talk. So without further ado, here's Dr. Poole.
Thank you, Lou, for those kind and inspiring words. So we're going to talk about chronic kidney disease in the current year, and there's a few things that have changed. A lot maybe has not, but this is a way to maybe introduce folks to some concepts in general about chronic kidney disease, and also some newer things that have happened in just the last couple of years. So we're going to talk about what does the GFR actually mean, stages of chronic kidney disease, who we should be concerned about, talk about GFR preservation, which patients that see me in the office are keenly interested in, some about hypertension studies, anemia treatment, and then some of the newest stuff about SGLT2 inhibitors, finerenone, which is a fairly new drug in the marketplace that may or may not be helpful to add, a little bit about metformin, and then something about acidosis. So I think it's important to define what CKD is. GFR less than 60 for greater than or equal to 3 months, with or without kidney damage. And kidney damage, and for the most part, means do they have proteinuria or not? And they can have kidney damage, i.e. proteinuria, with or without decreased GFR for greater than 3 months. And these are old definitions, but they still pretty much hold true. And if you look at GFR, there should be an E in front of that because we're really just estimating it. It's not a true actual measured GFR. Derived from a lot of different equations. Presently, they use gender, age, weight, and race. MDRD is the most commonly used one. There you see the eGFR equation. There was a guy down my hall at Georgia Tech that we called Rain Man that probably could do this in his head, but most of us will rely on the lab to generate this information for us. There are some issues with the equation, however. Primarily, creatinine's not the most ideal filtration marker. Generation of it is affected by a few different things: muscle mass, protein intake, and age. And it is secreted somewhat. And you can see drugs that can affect its secretion, cimetidine, which is the old H2 blocker that will increase the creatinine slightly. And of course, our old friend trimethoprim. And then GFR has some fairly limited utility in acute kidney injury because of the non-steady state nature of the patient. We still occasionally will do 24-hour urines for creatinine clearance. It's helpful for people that are very muscular folks, or if somebody's potential transplant donor. The accuracy of the equation is not as good at higher levels. And there has been a big discussion in the last year and a half about, is the race component helpful, harmful? You'll notice that when you get the report, there's African-American, non-African-American numbers. Actually, the work group of the ASN and NKF just yesterday released a statement that essentially they're working on how do we perhaps look at resolving and not using race in the equation. It is problematic if for lots of reasons. So that may be something that it will be addressed or is being addressed, just may take a couple of years to get formal recommendations from NKF/ASN. Things that affect creatinine generation, older female sex. The reason why there's the African-American versus non-African-American dichotomy is that in general, African-Americans have increased creatinine generation. Obviously, chronic illnesses will decrease it. Vegetarian diets will decrease it. Ingestion of cooked meats will increase creatinine generation. So why is the MDRD used? The old Cockcroft and Gault equation, Dr. Lambiase and I are old enough to remember when that was used a lot. It's been supplanted by the MDRD primarily because of the line of identity that you see there on the left side there with the MDRD equation more accurately hugs, if you will, the line of identity for actual measured GFR. So that's why it's used today. So why do we need to assess the GFR? Obviously, you need to figure out, do they have CKD or not? There's a whole host of reasons. Obviously, we want to provide some prognosis for the patient and also look at different treatment options. One of the big ones in looking at change in GFR level is monitoring for drug toxicity. There's lots of drugs that are renally cleared or can impact the kidney function. So we have to look at changes in GFR to accurately tell us, are we dosing the drug right, or is the drug affecting the GFR? This just shows what a creatinine of 1.2 is in different age range folks. So that's where the GFR is among 3 different patients, creatinines of 1.2, and where their stages of chronic kidney disease are. So you've got to, as a lot of my old attendings said, you've also got to look at the number, but most importantly, look at your patient. Proteinuria is something that is important to have a concept of. It generally reflects some degree of kidney injury, and it refers to increased urinary excretion of albumin or other proteins. Albuminuria is most sensitive for diabetic or hypertensive-related chronic kidney disease. Microalbuminuria just means it's greater than normal excretion, but below detection of what most routine tests are for proteinuria. Proteinuria is not great. You have an increased risk of dialysis, cardiovascular disease, and death with it. How do we assess this? 24-hour urine period is the most accurate way to assess it. We use spot protein to creatinine ratio in general to assess this, however. It just makes it where the patient doesn't have to collect urine for 24 hours, and most patients aren't huge fans of that. So the ratio gives you an idea of how many grams or milligrams they would excrete in 24 hours. Stages of chronic kidney disease. So 3A and 3B, they actually about a year ago changed the ICD-10 code so that you can't just say stage 3 anymore. You have to either stay stage 3 unspecified or stage 3A, 3B. There you can see the breakdown. Stage 5, less than 15, says kidney failure, but not everybody with a GFR less than 15 is on dialysis, or should they be on dialysis? So what do we do with these various stages? Every stage along the way, I look at, well, why are they here? Why do they have the current level of GFR that they do? What are the risk factors for progression? And what should we be doing to treat those? As they get into CKD4, we have patients that we looking at, are they going to need renal replacement therapy? If they are likely to do so, then it's important to get them educated, their family educated about modality of renal replacement, or if they're not medically able to possibly do any renal replacement therapy, very elderly with lots of comorbid conditions, how do we, if and when their kidneys fail, how do we get them involved with palliative care and hospice? A little bit about imaging. We do a lot of renal ultrasounds in our office. There's lots of other ways to look at kidneys. Ultrasound's cheap, fairly painless, and doesn't expose them to any any IV dye, obviously, or any radiation. So that's a pretty good test. CTs are still done, of course. MRIs are done. Occasionally, nuclear medicine studies are done, particularly if you have a patient that you need to take a kidney out for some reason. What does the remaining kidney have left? So when do people need to see us? The guidelines say if their eGFR is less than 30 for sure. If they're less than 60, if they're deemed higher risk for progression. So who are those higher risk for progression folks? Lots of proteinuria. Their GFR is changing in a bad way over a short period of time. Resistant hypertension, persistent hyperkalemia. And I tell primary care folks that if you have somebody that's not taking their comorbid diseases seriously, like they're not wanting to manage their diabetes well, not being serious about their hypertension, we're happy to see them in a way to maybe make them somewhat scared straight, because everybody that sees us thinks they're going to start dialysis. But this is not the case. If you look at this, this is some pretty old data, but it's still pretty interesting and accurate in the sense that people that have GFRs 30 to 59, they come to us, think, well, you know, they're going to put me on dialysis. But if you look at this, this was what they looked at is 5 years out, pretty big group of people, 28,000 patients. Well, what happened to those people? Well, only 1.3% needed renal replacement therapy, but 24% died, mostly from cardiac causes. So this is a high risk group for lots of badness, if you will. Their biggest concern should be managing their comorbid conditions. And at that point, not as much worried about, are they going to need dialysis or not? And people that are on, this is a very old slide, but top line in red shows what the CV mortality of people on dialysis. The blue lines are general population people. And you can see even quite young people that are on dialysis have a very high cardiac mortality. So even a 40-year-old patient on dialysis, they're just not, they have a lot different risks for CV death than their general population counterparts. And this just shows the people that are on dialysis, that have chronic kidney disease, their comorbid conditions. Far left is a CKD4 group. Most of them have hypertension. The kind of tan line bar is people that are unable to walk a quarter of a mile, which is about a quarter of them. So this can be a pretty frail population as well. So we'll talk a little bit about hypertension. Lots of studies, lots of acronyms. What targets do we shoot for? Targets change as patients age. There are side effects to a lot of these medicines that we have to deal with. This is kind of a potpourri of studies going back to 1998 with UKPDS, looking at intensive glucose control and how it affected albuminuria. All the way down to Credence, which was in 2019, which we'll talk about in a minute, which the Flozins are one of the latest, greatest things to add to both renal and cardiac armamentarium. You'll also see the On Target study from 2008, which we'll talk about, in more detail in a little bit. So these are some of the previous targets that were put out by JNC8, KDIGO, and KDIGO just came out this year with a new set of guidelines that we'll go into in more detail, and is actually recommending a systolic blood pressure of 120 or less. So we'll talk about that change. There you see what KDIGO had about 9 years ago. And they had various targets depending on your stage of chronic kidney disease and did you have proteinuria or not. So this just came out this year, in March of this year. And KDIGO is an international consortium, and the K is obviously for kidney and D for diseases. So, so this is what their recommendation is. So top part, sodium restricted diet, increase your diet, your activity level. those are things that are good for everybody. 2 grams of sodium per day diet. I think if you walk past the McDonald's, you'll probably pass that already. So that's a tough ask. Physical activity is sometimes often difficult to motivate people. The bottom part, where it talks about blood pressure targets, target blood pressure of less than 120 when tolerated using standardized office blood pressure measurements. And the next slide will kind of show what that looks like. And I would tell you in our practice, I think we try to do a better job of measuring in-office blood pressures, but it's a lot more difficult than just throwing a blood pressure cuff on somebody once as they run back to the room. So this is the 6-step plan of how to do this. Patient relax, which if they're seeing me for the first time, they're probably not relaxed because they're convinced I'm going to put them on dialysis. They're supposed to wait for 5 minutes. They're supposed to avoid caffeine, exercise, smoking for at least 30 minutes. Make sure they've emptied their bladder, which in our office, we've usually at least accomplished that part. So there's a bunch of steps to do to do this accurately to get good office blood pressure readings. So most of this, what they've modeled their recommendations is after the SPRINT trial. They started with a 2 or 3 drug regimen using thiazide type diuretics and or ACE or ARBs, but not both, and or a calcium channel blocker. And you can kind of see how the flow chart works. The biggest thing is getting accurate in-office blood pressure readings. Now, we have started using a lot of home blood pressure readings. We have a program that does remote monitoring, and there's a couple other groups in town that do this as well. In their paper, they don't have a recommendation about that just because there's not a lot of study data on how good that is. I'm hopeful that as we accumulate more information globally, that we can have some guidance on how to measure and use home blood pressures in clinical practice, because I think they do have a pretty good role, because I tell people all the time, I care really about what is your blood pressure when you're in your usual environment, because hopefully they're at their home a lot more than they're in my office. So this just kind of recaps for everybody the various classes and how they work. You've got the centrally acting alpha agonists, beta blockers, the ACE, ARBs, dihydropyridine, calcium channel blockers, direct vasodilators, and the dihydropyridine, calcium channel blockers, and direct vasodilators will often cause lower extremity edema. It's important to have that conversation with the patient ahead of time, because particularly most people will notice that, and they may not be a big fan of that. At the bottom, you see the thiazides, loops, and MRAs. We'll talk a little bit about the MRAs a little bit later. And like I mentioned earlier, there's a newer MRA finerenone. So what do we use for blood pressure control? ACE, ARBs, MRAs. They all have shown antiproteinuric benefits. Some combinations work, some don't. I'll talk briefly about the ARB recalls, which we've kind of forgotten about because of this pandemic that we've been living in for 18 months. But there was a lot of recalls in the summer of 19. Home blood pressures, I think, do have a role if you can get accurate data and consistent data. So the systolic blood pressure goal of less than 120, and then the KDIGO statement, they actually mentioned that this is not a renal protective target. This is a cardioprotective target, which I'm a big fan of the kidneys, but you need your heart to work well to stay upright. And then there's some words of caution. This is a very old slide from Biff Palmer, but why do people get acute kidney injury with ACE or ARBs? So the old thing you learned your second year or first year of medical school, renal artery stenosis can cause acute kidney injury with either of these agents. Polycystic kidney disease, I've not personally seen that happen much, but number three, I pretty much see every day. If somebody has decreased absolute or effective circulating arterial blood volume and they're on an ACE or ARB, they will get them up in their creatinine. NSAIDs is another agent, of course, that people elect to add to their regimen. Cyclosporin and tacrolimus, because of their vasoconstrictive effects, can be additive in causing or contributing to acute kidney injury. And of course, sepsis, that's kind of a no-brainer and part of the decreased arterial volume. This is the glomerulus, which is where a lot of us spend our time conceptually, but just to remember that the ACE inhibitors dilate the efferent arteriole, and the ARBs will contribute to dilating that efferent arteriole to decrease the glomerular capillary pressure. And that's part of why these agents are helpful in preventing progression of proteinuria or decreasing proteinuria. So just quickly about the OnTarget study. Most of you aren't old enough to remember when we used ACE and ARBs together, but that was all the rage when I came into practice. This looked at ramipril and telmisartan together. And basically you can see what happened to the GFR. This is the decrease in GFR. The purple line at top shows what happens with ramipril and telmisartan together. And they both, together, they had a greater decrease in GFR. So combination therapy with telmisartan and ramipril was not more effective in reducing primary outcome, more adverse events. So this was in 2008. So ever since then, nobody should be on an ACE and ARB together. So that ended that. This is briefly about ARB recalls. So this for a couple of reasons. Number one, it's important to know, most of us will pick an ARB that we're familiar with, comfortable with. But then 2019 happened, particularly earlier that year and in the summer, lots of recalls for NDMA contaminants in valsartan, which I had used a fair amount of. Then losartan was impacted. And so you had to be somewhat mobile in your ability to switch people to different ARBs. That's problematic for lots of reasons. Number one, it erodes patients' confidence in the drugs you're giving them. Like, well, the drug you're giving me may cause cancer. And so they become more reticent about taking their medicine. The other point of showing this is to show a actual plane wreck that we got to look at, and my kids found it on Instagram. And this is drug related because this supposedly was at the end of a runway where they used to run drugs in and out of the Bahamas. So, but there is some good you can find on social media. So my kids actually found this on Instagram, figured out where it was, and we were able to locate it and snorkel over it. So a bit about MRAs. MR blockade. This is a busy slide, does lots of things from a kidney standpoint and also a cardiac standpoint. And it can help prevent progression of CKD, prevent CV outcomes. It's obviously antiproteinuric, antihypertensive, and we'll talk more about finerenone, and that's a recent drug that came out, I think, just this summer. So what are the ACE? You add that with an ACE/ARB, but not ACE and ARB. What are the GFR effects? Some improvement in GFR as far as how it favors that combination. Proteinuric effects are more pronounced, as you can see on the left there, that ACE/ARB plus MRA generally has a significant improvement in proteinuria. So management of hypertension in these folks can get a little bit complicated, but this, basically if they have proteinuria, they should be on an ACE or ARB. And then plus or minus other agents. and then if they're uncontrolled, what you can add on. And patients get overwhelmed by the amount of blood pressure agents sometimes they require, and coaching the patient, getting them to understand that we're adding this medicine on because the number of medicines is important to a point. However, what's most important is getting your blood pressure under good control. And if they want to take less medicines, well, look at your salt intake, weight loss, the other things that are sometimes heavy lifts with patients for sure. So this is finerenone. This was a study that came out in a New England Journal earlier this year, and somehow they got Fidelio/DKD out of this. I'm not sure how the acronym. I tried to make it make sense, but I couldn't get it really to make sense. But anyway, I guess we're always in nephrology starved for neat names. So what is finerenone? It's a non-steroidal selective MRA. So it's more selective than eplerenone, because when this first came out and I said, well, what's the difference between this and eplerenone? It's more selective as far as how it binds to the mineralocorticoid receptor. So this is a study of 5,700 people, type 2 diabetics, GFR range 25 to 60. They all had albumin to creatinine ratios of 30 to 300 with diabetic retinopathy, or they had more significant proteinuria with a little bit broader GFR range. Importantly, they were all already on an RAS agent, so they were either on ACE inhibitor or ARB. Primary composite outcome looked at loss of 40% of the GFR, renal failure, or death from renal causes. Study of about 4 years. So the other question I had, well, how much does this add-on feature cost? And I looked on GoodRx. Finerenone's about $500 a month. Eplerenone's $30 a month. So, but compared to the control group with placebo, lower incidence of primary composite outcome, lower incidence of decrease in the GFR, 40% from baseline, not a huge difference in kidney failure, decent split with secondary composite outcome. So data that's, I wouldn't say compelling, but does show that it's helpful. Albumin to creatinine ratio, it does improve that perhaps a little bit more markedly. The last box is the serum potassium, which, as you might imagine, in general was a little bit higher. And this just shows some of the confidence intervals of how it affected certain outcomes. Death from cardiovascular causes was less, hospitalization for heart failure a little bit less, secondary composite kidney outcome improved, end-stage kidney disease improved somewhat. So it does have some benefit over this 4-year period, but it's pretty pricey at this point. This is a way too small for you to read, but my point was to show the hyperkalemia, which is what keeps a lot of us up at night. So in this study, about 16% had incidence of hyperkalemia compared to 8% in the control group. So that's something that we've got to keep our eye on when and if these people get started. The RAILS trial, which came out several years ago, and looked at adding on aldactone at that time, because eplerenone was very, very new or not even out yet. But what happened to these folks once, as far as their potassium and the risk of hospitalization for hyperkalemia went up because we were using a lot more of these agents. So Dr. Ronco wrote this commentary. He's a well-known Italian nephrologist who puts on a great meeting every year outside of Venice, Italy. So if you want a good meeting to go to, that's the meeting to go to. But they just commented that we should be aware. So I think people that are on all of these agents, be it newer or older MRAs, got to do follow-up labs. We have some options to treat hyperkalemia, but they're not cheap. So patiromer is one option. A single dose is $50. Sodium zirconium cyclosilicate, one dose, $28 to $30, depending on what strength you use. The old Caxolate is cheap. If you can find it, it's not sometimes readily available. The patient Yelp reviews for it are rather poor because it tends to be a fairly violent experience for them, much like some of the stuff Dr. Lambiase gives people in preparation for a colonoscopy. The patiromer and other agent are a lot more well tolerated. Like I said, they come in at an expense. So if you add finerenone at, a few hundred, 400, 500 bucks a month, and they need to take one of these binder agents a few days a week, you can see that you're working up to a pretty healthy house payment just with those two agents. All right, so some about anemia. Anemia and chronic kidney disease, everybody sees it. How we treat it has definitely evolved just in my practice lifetime. I'm not old enough to remember what life was like for dialysis patients before ESAs. They came on the market in the late 80s, but dialysis patients often ran around with hemoglobins of 5, and their quality of life wasn't so good. But now may have allowed patients to live with lower hemoglobins than they did when I first came into practice, and this is some of the reason why. The normal hematocrit study that came out when I was a resident, that was looking at if we normalize their hematocrit, in other words, my hematocrit's 14 or 15, whatever. If we make a dialysis patient's hematocrit 14, 15, what happens? It was stopped early because that wasn't such a good idea. So we never did that. Choir, Create, and Treat looked at some pre-ESRD people and how we treated anemia and chronic kidney disease. Choir showed that there was harm in getting their hemoglobins closer to even 12.5, 13. Create showed no benefit in doing that. And then the Treat study, which we'll talk about in a minute, which we were actually asked to be a study site, but we declined because we thought, well, getting these people's hemoglobins down to 8 seems like not a great idea. So this was placebo versus darbepoetin, which is the trade name is Aranesp. Hemoglobin 9.3 in the placebo group, 11.3 in the treatment group. Original trial had about 4,000 people, 600 of which went on to dialysis during the study. And the Darbo group is in the dashed line, and their all-cause mortality. You can see the difference there, so not great. Stroke risk was higher in the darbepoetin group, so increased risk of stroke in those folks. And so what do we use today? Look at their iron stores. Have they had a colonoscopy? If they haven't, should they get one? They should probably at least have that discussion with the patient. Look for blood loss, stuff that just means being a good doctor. Also discuss the risk and benefits with patients. These drugs are not benign. We target hemoglobins between 10 and 11. We even do that for our dialysis patients now. We don't start the ESA really discussion until their hemoglobin is closer to 9. Blood pressures must be controlled well. If people come in for an injection of some kind of ESA, blood pressure has to be checked. If it's above a certain level, they don't get their ESA. In the dialysis world, we've become much more prudent about how much ESA they get. Are we staying on top of their iron stores and whatnot? All right, so we'll switch gears and talk about Credence. Most of y'all are too young to know who Credence Clearwater Revival is or was, but anyway, Credence is a neat name they came up with for study involving one of the SGLT2 inhibitors. This looked at diabetics. They were albuminuric. They had chronic kidney disease, pretty wide GFR range, 30 to 90. All of them had albuminuria. all of them were on RAS agents already. So what it looked at is how many people went for a composite outcome of end-stage kidney disease, doubling creatinine, or death from CV or renal causes. So this is a pictogram, if you will, of what the study looked like. So they all had proteinuria. They were on a maximum dose tolerated of ACE or ARB for at least 4 weeks, and they were randomized. The treatment group had to prevent one primary outcome, number needed to treat was 21. To prevent end-stage kidney disease, number needed to treat was 42. Amputation and fracture risk was not increased in this study. So people with type 2 diabetes and kidney disease, this SGLT2 inhibitor reduced the risk of kidney failure and cardiovascular events. So good things that we want to prevent dialysis. We also want to keep people alive longer. So what did it do? The canagliflozin, what did it do versus placebo as far as proteinuria? As you can see, the blue line there shows that it reduced proteinuria. The graph below is one that I've probably drawn on the back of my patient list 100 times to residents, medical students, about what happens with their GFR when you put somebody on an ACE or ARB. Okay, you'll see some decrease in the GFR, but at a period of time, and that period of time may be 2, 3, 4 years, their GFR should and will be better on that agent. Similar curve with the flozins. You can see initially you will see some decrease in GFR. The patient and the provider all need to not get too freaked out by that. Just know that it's probably going to happen, but just hold on. And over time, particularly after about a year, things will, at least the paths at least cross. And then as you go out 3, 4 years, you're better off being on this agent. Now, this is just GFR change, not to mention some of the, or all the cardiac benefits, which we'll get to here in a second. So this looks at lots of different parts of the study, but the flozin agent, and there's actually a nephrologist that has out of Detroit that has a flozinator button that I haven't gotten one of those, but anyway. So the flozins are definitely the wave of the present and future. But you can see the SGLT2 inhibitor in this study, much better outcomes is with any of the parameters they looked at. And this just shows at various GFR breakdowns how beneficial it was. It tended to have more bang for their buck, if you will, in the 45 to 60 group. And if you had higher degrees of, higher levels of proteinuria, renal specific outcomes, pretty similar. So the point is to get these people on these agents perhaps earlier than when they might get sent to someone like myself. So this looked at particularly the cardiac outcomes. The kidneys are important, but I'll have to give the heart its due. It's pretty important as well. So these are people that don't really have much in the way of chronic kidney disease, but they do have diabetes. So what happened with them over time? Fewer, the primary outcome, composite CV death, non-fatal MI, non-fatal stroke, we decreased 4.6 events per 1,000 patient years. There was some increased risk of amputation, which if you have somebody that has bad peripheral vascular disease, you need to look at that closely before initiating one of these agents. This is another agent looking at mortality in diabetic people. About 10% of these people had true diabetic nephropathy, decreased risk in the primary outcome, CV death, and total mortality. So pretty much any study you look at, these agents have benefit from a renal standpoint and cardiac mortality standpoint, and that's why they're heavily in use. I think there are still issues getting the drugs to the patients because they're not cheap, because they're all new drugs. This looked also at cardiovascular outcomes, people specifically with chronic kidney disease. For every 1,000 patients with chronic kidney disease treated for 5 years, 65 fewer cases of the composite CV death, non-fatal MI, non-fatal stroke, and 18 fewer cases of end-stage kidney disease / renal death, or 40% decrease in GFR. Decrease hospitalizations for heart failure, which should encourage insurance companies to add this as an agent to the formulary, and 25 more cases of amputation. So, and I think any amputation would be major in my book, but they broke them down into minor and major. This is another study looking at canagliflozin on renal outcomes. There again, these are people that are diabetic, that have cardiovascular disease. In these patients, reduced risk of the renal endpoints, reduced GFR decline, and also had fewer patients that developed albuminuria, and then reduced risk of renal adverse events as well. So this is some recap, and you'll see that the SGLT2 inhibitors are always on the left side of this line, looking at no matter if your stage of CKD was 1 through 2, even people in stages 3 through 5. And looking at major cardiovascular events, not as profound looking, but definitely an improvement. And there again, these studies probably don't have enough time course to measure and show improvement of the significant nature with cardiovascular outcomes. But the longer people are on these agents, more experience with them, I think this data will look even more robust. So I will nerd out here for a few minutes just to show you what happens on the glomerular level with SGLT2 inhibitors. Obviously, this decreases sodium and glucose reabsorption. And the endpoint of all that is that you have some afferent arterial dilation, which leads to some decreased pressure in the glomerular capillaries, which sounds a lot like what ACEs and ARBs do. So at the end of the day, and that's why you see some drop in the GFR initially, but over time, this has been proven to be a beneficial response at the glomerular level. The kidney-heart connection for organ protection. As you can see there, lots of this is very interrelated. How the plasma volume affects sympathetic nervous activity and nervous system activity. So all this is very interrelated, and I think the SGLT2 inhibitors and the MRAs particularly as well highlight a lot of the interrelated nature of how we treat kidney-related issues can definitely have some positive impact on cardiac livelihood. A bit about Fournier's gangrene. If you mention it to some patients that you start on this agent, they'll look like this little shark that I encountered in the Bahamas. They will be a little put off by that. I looked again last night and couldn't find a recent update, but a year or two ago, there was 55 cases reported over the first over a 6-year period. So it can happen. So you have this ongoing glycosuria. So that's one way to tell if your patient's taking their SGLT2 inhibitor, do they have glucose on their urine dipstick? If they don't have any, they're probably not taking it. So this was from 2019. It wasn't agent specific, so all of these agents can do it. Typically happened within the first month or two of initiation. Obviously, if you've ever dealt with Fournier's gangrene, morbidity is pretty awful. So few reported recent UTI or peritoneal hygiene difficulty, which sounds like a malady I would not want any part of. But so if people tell you that they've had a lot of UTIs or they have risk factors for hygiene difficulty in that area, maybe they don't need this agent. And then educating high-risk people on the front end about what to watch and be mindful of. So these agents appear to be a pretty good weapon in the fight on type 2 diabetes. Currently, you can initiate this agent with their GFR greater than 30. There are some studies that have looked at using it initiation of 25 or greater. This appears to be in some evolution. Currently, there's not a GFR. We'll talk about metformin in a second. There doesn't appear to be a GFR floor as to when you can stop it. I think for sure if they start dialysis, they need to be stopped. But they just require maybe closer monitoring. Reactions to watch for: yeast infections, Fournier's gangrene, UTIs. DKA without hyperglycemia has happened. I think we've seen 1 or 2 cases. Amputations, fracture risk, we're not seen in some of the studies, we're seen in some of the studies. And obviously acute kidney injury, you can bet that there's going to be some decrease just because they're going to often experience this pretty significant osmotic diuresis as they dump a lot of glucose in their urine. So this just quickly looks at, this is from KDIGO, drugs to use for type 2 diabetics. Obviously lifestyle therapy should be tried first and foremost. Metformin, if their GFR will permit, and we'll talk a bit about that, and using an SGLT2 inhibitor. These are the other agents that can be added on, but between, if their GFR will allow, metformin and SGLT2 inhibitors are a pretty good start that don't tend to bottom out people's blood sugars. This is an algorithm. If their GFR is greater than 30, adding on the SGLT2 inhibitor. So a bit about metformin. A lot of misinformation out there about metformin. It does not cause kidney damage. It does not. Because patients, and they get it in their mind, if their GFR decreases, they stop the metformin, that must have been the reason why their GFR decreased. So when I was in training, serum creatinine cutoffs were 1.5 for men, 1.2 for women. About 10 years ago, they finally put it in GFR parlance, which made a lot more sense. So if their GFR is 30 or better, if they're stable and on therapy, they can stay on it. Caution to start if GFR less than 45. There again, this is a drug that probably does better if you start earlier. There is a risk of lactic acidosis. It's rare, does exist. Oftentimes people will come in shock, and guess what? They have lactic acidosis, and guess what? They were also on metformin. So how much it contributes, but I would say there was probably only been a very small number of patients that had normal blood pressures that came in with lactic acidosis due to purely metformin. In the CKD stage 3 people in the TREAT study I mentioned earlier for ESA use, there was less CV risk in the metformin users. In that study, there was 2 episodes of lactic acidosis in almost 600 patients. So this looks at what happens with folks that are on metformin and that have chronic kidney disease. They had less all-cause mortality, less CV death, about the same rate of ESRD. So it at least appears to be safe to use in folks that have CKD. And so this is a little flow chart about, if their GFR is less than 30, don't start it, don't keep them on it. If their GFR, if they're on it and their GFR is 30 to 45, you can initiate at the half dose. So this is basically my pitch to use metformin. It may help people lose weight, which is a good thing for diabetics in general. Speaking of acidosis, there's another abnormal lab value and a sea of very abnormal lab values in our people. In ESRD patients, people will have bone loss because they will use bone phosphate to help buffer the acidosis. So does it really matter, and how so do we treat? So people with CKD and metabolic acidosis, bicarbs usually less than 22, The recommendation is to treat with oral alkali. They mentioned sodium bicarbonate or sodium citrate. Sodium citrate is usually a liquid form that's absolutely deplorable. So I would not recommend that unless you have disdain for your patients. So what happens with these folks, if you look at the active treatment group in the white bars, their change in bicarb went up and their GFR decline tended to be less than the solid color control group. So there is some evidence that there may be some slowness in how fast the GFR decreases. And this looks at the ESRD over a period of 2 years, less ESRD development in people that were on the active treatment group of getting bicarb and treating to a bicarbonate of about 22. I think it does need to be studied more in CHF patients and poorly controlled hypertensive patients because you're giving them sodium bicarbonate. Sodium citrate, as I mentioned before, I would not use that unless you absolutely had to. Sodium bicarbonate is just baking soda that's in a tablet. You can see the math there of what a milliequivalent per liter and a millimole per liter for bicarbonate is. About 650 milligram tablets is about 8 millimoles of bicarbonate. 1 tablespoon has about 60 millimoles of bicarb, but you will be hard pressed to find people that will take a tablespoon of baking soda extremely willingly, but there may be a few out there. So a bit about, who gets sent to us or who should be sent to us. GFR equation, there's been older nephrologists that said gentamicin sent my kids through college. I couldn't get my kids out of the driveway with gentamicin consults currently, but the eGFR equation has greatly increased our CKD population and clinic traffic. Some need our help and some don't. Some that, discerning who needs us, who doesn't, not always clear, but there are some clues. If their GFR is less than 30, absolutely they need to see us because they may be heading toward need of renal replacement therapy. Obviously, if they've got acute kidney injury, if they had a GFR that was very normal and all of a sudden now it's 40, well, that's something that we should perhaps look into. Proteinuria, the cutoff that they use typically is 500 milligrams a day. Those people are at higher risk for developing serious renal complications. So this just kind of breaks that down. If they have proteinuria, no matter what their GFR of significant magnitude proteinuria, they need to see us. And as their GFR goes down into the 3B, 4 group, then they probably definitely need to see us. So always get the question, the MDRD equation is not very, wasn't really studied in people that are older, as in 80 plus. So what do you do with an 80-year-old with a GFR 55? Does she have chronic kidney disease? What risk does she have for ESRD? How do we explain this to patients? One of the great blessings and curses of the EHR is that patients have a portal. If they're not getting on there, their third cousin who may have gone to nursing school and is a nurse wants to know all their labs, and they talk to you about why is their chloride abnormal. So they're definitely going to ask you, well, why is their GFR 55? So what happens to these people as far as their mortality? Older people, that's if they have proteinuria, they have a higher risk of mortality for sure. Adjusted hazard ratio for ESRD, the older people, their GFR is 40 to 59. If they have proteinuria, they do have some risk of developing ESRD. Now, what do we do about that? If they do develop ESRD and they're 93, that's a discussion you've got to have with the patient and their family. I will say that I have a lady at my dialysis clinic that will be 99 in February. She walks in with a walker, very pleasant, and enjoys life. So age is truly but a number, but you need to discuss with the patient and their family, what do they want? What are their goals with all these folks? So, but the point is the older kidneys are indeed fragile, greater risk of acute kidney injury with hospitalizations. If they have acute kidney injury, they have a greater risk of needing hemodialysis. And then they have a greater chance of developing chronic kidney disease after an AKI episode. So my point is to, make sure you prescribe carefully And I think the GFR equation, if nothing else, helps elucidate that, their kidney function, if they're 75, 80, if their creatinine's 1.1, they probably don't have great kidney function. So you need to look at, well, do they really need this Bactrim and the Celebrex and so forth? So in summation here in the last few minutes, we're all actively treating chronic kidney disease every day, whether or not we know it or not. Controlling blood pressure, blood glucose remain very much key. SGLT2 inhibitors are joining the RAS agents in the must-have group, I think, provided we can get the medications to the patients. Thankfully, just about all ARBs are generic now or close to it, which is very helpful. I tell patients my goal as a nephrologist is to help the patient's kidneys live exactly 1 day longer than the rest of them. And so that's kind of my job. And then hopefully with better predictive models, we can discern who really needs early intervention, especially those in the older group. And then my old division director said, you are what your kidneys choose to keep. So that's, I'll stop there and then I guess entertain questions or not.
I have a couple of questions.
Yes, sir.
The benefit on GFR from sodium bicarbonate, is that from the bicarbonate or from the sodium?
That's a good question. I guess, well, their bicarbonate's definitely improved. Okay. So you would like to think that, well, we made their bicarb better, so that helped their GFR, but that's, I guess, yet to be teased out. But
the other is a comment. I think that, I think that the hypertension guidelines and all this, the algorithms are really great, but I think one of the key points for internists in managing this is really managing side effects.
Yeah.
And, as a gastroenterologist, I see people on a tremendous number of medicines whose stomach hurt, and then they come to see me because their stomach hurts, and you look at their medicine, and, a lot of these medicines, nausea, constipation, diarrhea, are all top-line side effects. And so you sort of have to pick something that your patient can live with. And then the other thing is losartan can also cause a celiac-like enteropathy, so something to think about if somebody might have that as well. But I think side effects and polypharmacy, when you add, you may want to drive, because the algorithm tells you to drive the blood pressure down, but you're making the patient's life unlivable. And so you just have to be very adept at changing medicine and pruning med lists.
Yes.
And that sort of thing.
Yeah, and one of the caveats they do give in the guidelines is that it does mention patient tolerability of all that. So you can prescribe, and we all learn this pretty quickly, you can prescribe and wish whatever you want, but unless the patient's going to take it and feel okay on the drug, then you're on a fool's errand. You're not going to get anywhere, because if they're nauseated, dizzy, lightheaded at home. So that's why I like using home blood pressures as well, because if the patient's blood pressure is 118 in my office, I'm concerned, is it 97 at home sometimes, and then they can't get off the couch, and then, or do they have nausea from all the medicines I've given them? So you really have to get patient buy-in and have them to be honest with you about how they're feeling with the medicines. If they feel awful, then you're going to have to regroup.
And I would say that this is where a good internist can bring value to their patients. Anybody can, Google the guidelines. My daughter who works in fashion can do that, right? And pick whatever medicine, but really understanding the pathophysiology and trying to get a cocktail, as you were, of medicines that achieves the goal and also the patient can live with is really where I think as interns we can bring value to the patient.
Yeah.
Anybody else have any other questions? I don't know if we can get something from this. No, from no feedback?
Yeah.
No? All right. Well,
All right. Thank you, guys. Yeah, we'll see if we can get something accomplished by then.
Yeah, you see our guy at CVICU pass last night?
Yeah, I saw his